Thank you, Mr. Jackson. Thank you, Mr. Mohammed. Appreciate your participation and contributions today.
Thank you for all that you do.
Thank you. Thank you. We're going to move on to our next panel, our health equity panel. Our panelists include Ruben Gonzalez, youth leader, Building Healthy Communities, Dr. Karen Smith, director, and Jamal Miller, deputy director, California Department of Public Health, Jennifer Kent, director, and Renee Malo, deputy director, California Department of Healthcare Services, and Will Lightbourne, director, California Department of Social Services. Thank you to all of our panelists in advance for your participation today, and welcome. If you want to kick us off, Mr. Gonzalez, whenever you're ready, please do.
Good morning. Can you hear me well?
Excellent.
Perfect. Good morning. My name is Ruben Gonzalez. I'm currently attending UC Davis, my second year. I just finished my first one. As it says, East Salinas youth leader for the Building Healthy Communities. And for those of you who do not know about East Salinas and its infamous name, well, let me start off by telling you that we have recently tripled the homicide rate in the United States and California as well. We have a high problem with gang violence, and to top that all off, most of our community is from the working class, working in the fields, agriculture, a lot of immigrants coming from all over the place to work for the low-income jobs, low skills. And through all these things, boys and men of color are predominantly looked after and almost attacked, and they face trauma throughout their lives growing up. And I'm afraid to say, by the age of 15 myself, I suffered many trauma. By the age of 15, I had witnessed 3 murders happen before my eyes. I had been at 8 funerals of people that I knew. And on top of that, my parents were immigrants, so when my mother got sick and was landing in the hospital every other day, we couldn't afford to pay the medical bills, and I slowly started losing myself. And it came to the point where thoughts of suicide came into my head, and approaching it as well. And through the days passed by, and I tried talking to the counselors, but they didn't really know how to handle the situation. They didn't know where I was coming from. They couldn't understand the situation of where my neighborhood. It wasn't until I was in an organization named LULAC that I came across Milpa. And they do something that's called La Cultura Cura. For those of you who don't know Spanish, that means the culture cures. And they took me through a process which is called Joven Noble, and it literally translates to noble young man. And they taught me about my culture, my ancient roots, and how to heal myself. And through the problems that I was facing, in Western society, that was seen as abnormal and strange. But what I learned through my culture, there's ways to heal. There's ways to fix things like that I'm not alone. And through this healing process, I finally made it to UC Davis, and now I'm better. I still implement all the strategies that I learned and how to heal myself whenever I feel any pain. And I feel like that's something that, in the health perspective, we don't think about. We don't think about healing ourselves mentally and trauma. We just see it as an abnormality. But in reality, it's something that can be healed and can be processed. And especially for boys and men of color, society doesn't see us as a way that it can be normally just fixed through, going through a regular school counselor. I feel that we need more healing aspects in health. We need to implement in schools that reflects the population served, and also focuses on trauma-informed health. La Cultura Cura helps individuals' overall health outcome by addressing trauma as a root cause for certain behavior that Western society would see as abnormal, as I said earlier. And I urge you to please speak out about health issues that address healing in the form of culture within our schools, and especially for people coming out of the incarceration centers. Thank you.
Thank you very much, Mr. Gonzalez. Mr. Miller and Dr. Smith.
To the chairs and the select committee members, we're honored to be here this morning on behalf of the California Department of Public Health and the Office of Health Equity. And before I introduce our new state health officer, I just wanted to quote a quotation from our president from a few months back, where it says, "What is also true is that the legacy of slavery, Jim Crow, discrimination in almost every institution of our lives that casts a long shadow, and that's still part of our DNA that's passed on. We're not cured of it." And the importance of that quotation to me is that it's consistent with an upstream approach that the Office of Health Equity has within the California Department of Public Health to deal with the social determinants of health and mental health in a deep and meaningful way by understanding that many of the institutions and organizations that have an influence on the outcomes of our health and our mental health, that we need to deal with them in an upstream capacity, and that they're very important, and they don't always fall within the traditional or conventional box of health and mental health as we understand it. So as I cite social determinants of health and going upstream, I want to transition this to Dr. Karen Smith. Dr. Smith was sworn in as our state health officer in March. She comes from Napa County as the previous public health officer there, and was trained, got her medical doctorate degree at Stanford University, and also has her master's in public health from Johns Hopkins. I'm going to transition to her to talk about the public health framework that we take to address health inequities in the state of California.
Thank you, Jamal. Thank you very much for this opportunity. I'm going to go quickly to try to give you some highlights of the work of the department over the past year, as well as the Office of Health Equity. The department really does take very seriously what Jamal was referring to as working upstream, which is to say that we recognize that health isn't just about health care, but also about the communities in which we live, learn, work, and play. And strengthening communities is in order to strengthen communities, could you forward that for me? It's all right. Got it. In order to strengthen communities, you also have to have strong families. And so a lot of the work of our department, both in our Center for Family Health, but also throughout the department, focuses on the most vulnerable communities, and that very clearly includes boys and men of color. You all know that about the Office of Health Equity, so suffice to say that the concept of health equity, while we do have a center for that, an office that takes that as its central mission, it's core to what we do throughout the department. Achieving health equity and creating population health are synonymous. We cannot have one without the other, and we take that responsibility extremely seriously. I think what I'm going to do is just jump right to one of the things we're most proud of. Last week, we released the Portrait of Promise, the strategic plan for achieving health and mental health equity in the state of California. The plan was developed with extensive stakeholder input, and it has two parts. The first part is a very comprehensive demographic report on health and health equity in California, and it presents a background and evidence on the root causes and consequences, frankly, of health inequities. It illustrates how this broad range of socioeconomic forces, including things like income, security, education, housing, transportation, environmental quality, and access to health care, shape the health of the community, especially vulnerable and underserved communities. And these are the factors that lead to the health inequities that we see in our populations. The demographic report is followed by the 5-year strategic plan. Goals were developed for each of the plan's strategic priorities, those being increasing knowledge of the problems and the possibilities that we can have through increased assessment of the issues, and really diving deep down into the community and neighborhood level to try to have data upon which to act. Increasing communication to foster that shared understanding that we need to have to be successful, and improving infrastructure development to empower residents and their institutions to act effectively to address health inequity. Throughout the plan, you will find a special focus on gender, This reflects our attention to the fact that inequities and also interventions often differ and are more or less successful in different genders. And so there is a very clear gender lens prominent throughout the entire community. And then the second project I want to mention is the California Reducing Disparities Project. I'm pleased to report that we're now moving into phase 2 of the project, which is to release the solicitations for the projects of the California Reducing Disparities Project overall. As you know, this has been designed to improve access and quality of care and increase positive outcomes for racial, ethnic, LGBTQ, and cultural communities in the public mental health system. So phase 2 solicitations will be released very soon in the next couple of weeks. So look forward to that. In the interest of time, I'm just going to mention I know you're all familiar with the Health and All Policies Task Force, and say that the task force continues its work, which has been very successful, and is expanding its reach into additional new collaboratives. We've been invited to the table by many new partnerships because of the outstanding work that the Health and All Policies Task Force has undertaken. I'm going to transition it back to Jamal. He's had the opportunity to represent us in a number of interesting forums which speak specifically to the issues of this particular special committee.
Thank you. And one of our recent invitations that we accepted was from the White House to attend the Office of National AIDS Policy's update of their and the launch of the National HIV/AIDS Strategy for the United States. And one of the pieces of information that stuck with me was the adverse and disproportionate impact that HIV and AIDS continues to have on African American men and also African American women. We developed and gathered a lot of information from conversations during that experience, and it's prompted us to work internally with our Center for Infectious Disease to address sexual and behavioral health issues. One other statistic I'd like to highlight when we think about sexual and behavioral health is ensuring equity when we think about issues around gonorrhea, for instance. Here's a statistic for California. Among males ages 15 through 19, the African American gonorrhea rate in 2010 in particular was 32 times greater than the white rate. And when we think of disproportionate statistics like that and the pervasiveness of those across social determinants of health, it really highlights the need for us to address those issues. Other partnerships that we forged as a result of being invited to the table are around going upstream in the life course when we think about our children. We've had the opportunity to partner with the California and U.S. Departments of Justice on the Defending Childhood State Policy Initiative, where we're looking to address childhood trauma and exposure to violence on a scaled state perspective. The second is an internal operation that we have called the Essentials for Childhood Cooperative Agreement that's funded by the CDC, and that's administered out of the California Department of Public Health. And then we're working with Dr. Nadine Burke-Harris and her team at the Center for Youth Wellness on the ACEs Policy Working Group Committee. And this models how important it is through collaboration and partnership for us to affect the kind of change we want to see around health and mental health equity. We're also partnering with the Board of State and Community Corrections when we think about opportunities we have around corrections and rehabilitation. I now sit on the Executive Steering Committee for a $5 million project that is modeled after the Social Impact Bonds model, and it's a creative way to invest into recidivism reduction projects. Other than just simply incarcerating people without rehabilitative components, this effort looks at the role of housing, unemployment programs, and a variety of other social services to shut down the revolving door when we think about recidivism reduction rate efforts, and we're honored to be at the table in that effort. I'm sure we've left off some of our key stakeholders across the state, but I wanted to just give an example of how we are fueled within the Office of Health Equity to do the work that we do. We truly believe that strong roots produce strong boys and men of color, and some of our partners that we've listed are in the room. Others aren't, but are continuing to do important work on a state and national level. And simply what we want to show here is we can achieve health and mental health equity without this select committee and other multi-sectoral efforts that are underway across the state of California. And at the end of the day, as we're looking at the closure of a great baseball season, we want to ensure that people's understanding of the social inequalities that contribute to persistent health and mental health inequities it's far more than just equality. But when we think about equity, it's ensuring that people who are allowed this opportunity to live this wonderful life that we have, our experience when we enjoy the ball game is comparable, and that it's the same. And some of us must accept the reality that we need a little bit more help in this endeavor than others may. So we thank you for this opportunity. And the last thing I'd like to say is I'm really, really grateful once again for Dr. Smith's leadership and her partnership. She is truly an ally in this work and will help to catalyze the kind of change that we want to see on this road to achieving health equity, and just wanted to share that authentically in my appreciation for you. Thank you.
Thank you, Dr. Smith and Mr. Miller. And let's go to Director Kent and Deputy Director Malo. Welcome, and thank you for being here.
Great. Good morning, chairs and members. It's a pleasure to be here. I'm struck by the fact, as I'm sitting here with two other of my sister departments, how closely we actually work together when you think about the various populations that we serve, both as an agency but as individual departments. Medi-Cal, within the Department of Healthcare Services, is obviously one of the largest health delivery systems in the entire country. We represent probably $93 to $94 billion in total funds that we spend every single year to support the health and delivery of care to individuals that now number almost 12.5 million people. So it is about a third of our state's population, and it is something that we look at not just in terms of sheer numbers, but there's also a lot of subpopulations that we have to adopt different strategies that require us to be working collaboratively but with both our other departments as well as other stakeholders. I think I wanted to touch just really quickly on some of the things that we are both negotiating with the federal government for how we work with some of these special populations, but I also wanted to note that in doing so, there's always more opportunity where we can do a better collaboration to get at these populations that are otherwise not either in the health system today, or they have traditionally been left out of a healthcare delivery system that does not speak to their interests and needs. And so with that, we are in the process of negotiating our 1115 waiver. Waivers in the federal government for state Medicaid programs are something akin to, I say, a story. And it allows states to go to the federal government and say, if you waive certain rules, this is what we are prepared to do to show that we can do something different that will both bend the cost curve as well as deliver care in a different way. And so we're in the process of telling our story to the federal government now. We are hoping to have that done by October 31st. But what this waiver is really about, it's a 5-year demonstration waiver, is how do we get at these populations that have traditionally not been in our system, either they're not necessarily in our system or they have not received the full scope of benefits. So touching on births for just a second, we cover half the births in the state of California today, and most of those births are delivered in a fee-for-service environment. These are either individuals that are only in Medi-Cal because of the basis of their pregnancy status, or they are without satisfactory documentation status. We are looking at our hospitals and we're saying we can do a better job in terms of delivering quality care, reducing unnecessary emergency C-sections, things of that nature. And so we have a specific piece in our waiver we are focusing on with the federal government that gets at getting babies born at the right time and as healthy as possible. The second thing that we want to look at in our waiver as we move forward is we have done a great deal of data around individuals that are seen as, we call them either frequent flyers or high utilizers in the system. When we look at the data from back in 2013 in Medi-Cal, there's approximately 25,000 people in fee-for-service, so that's about a 3 million population center for us. They cost about $7.2 billion in a single year. 25,000 people cost $7.2 billion in spend. They are extraordinarily expensive. And the reason for that, when you look at the data, is that they have serious mental illness, a mental health condition. They have several comorbidities. And so our waiver is really working with the counties and the various programs that are down in a local level to get at what we call the high-cost utilizers, and we call that the whole person care pilot. we really believe that the opportunity that lays in front of us as a state is to better integrate both the physical and mental health care. We just received, speaking of waivers, we just received our last waiver amendment on August 13th to do an organized delivery system for our drug and alcohol treatment services. And so this, again, is another opportunity that the federal government has allowed us, so that how do we bring people into the system and provide them care in a place that they're most comfortable, that is culturally and linguistically the place for which they most comfortably receive services. And so with that, I will stop and turn it over to Renee Malo.